So, good evening, everyone. This is the webinar under Aegis of UPOA, and the topic of this webinar is a debate between robotic and non-robotic total knee replacement surgery. So nowadays, there are two school of thoughts now. Many people promote robotics, non-robotics, and so everyone should understand the concept who should choose robotics, when to choose robotics, and what are the pros and cons of robotics and non-robotics. And we have an eminent speakers who are popular, and they are doing robotics and non-robotic surgeries, and they will tell us and give us insight about these two surgeries. And we have with us, first of all, I would thank UPOA and President and Secretary UPOA. And with us is our Secretary, Dr. Santosh Singh, sir, who will say a few words regarding this event. Dr. Santosh Singh, sir, please say a few words.
Chalega Santosh.
So we'll start with the session. So our first speaker is none other than Dr. Sanjay Srivastava, sir, from Apollo Hospitals, Lucknow. He's a renowned orthopedic surgeon, renowned robotic knee replacement surgeon, and a great teacher, a great mentor, and in all fields of orthopedics, I see him in guiding in all the WhatsApp groups, either whether it is Arthroplasty or Arthroscopy or any on any topic. He is a master of all the fields of orthopedics, and he has evolved himself as a robotic knee replacement surgeon, and he will give us insight about how he changed himself from a non-robotic surgeon to a robotic knee replacement surgeon, why he changed, and what are the advantages of robotic knee replacement surgery. So I invite Dr. Sanjay Srivastava, sir, to please give his presentation and share his screen. Dr. Sanjay Srivastava, sir, please.
Thank you, Dr. Imran, for beautiful words. First of all, I have not changed. I still do a lot of conventional surgery. And if you talk about numbers, then I think the conventional surgery is still more. Only 20% cases we are doing a robotic. So that's not the case. And reason I would tell you that there are many surgeons who are early adapter to technology, and the other surgeons who take a little time to consider. I'm one of the person who believe that to have a real feel of the technology, if I find it useful and conducive for me. And so that is why I think I have started doing that. I'll come to the point. My representation is not about robotic, how I do it, or it is just to understand what is robotic and how it is helping and how it is growing. That's all. It's a very basic presentation. So, and then rest of the thing we'll discuss in discussion. Total knee replacement, as we were just discussing, one of the most wonderful surgery of orthopedics. We have got wonderful results. Majority of our patients, they are doing very good and they are happy with the result. We are able to provide them a painless mobile joint, which is lasting good enough for majority of our patients. And there's no doubt about it that it is improving over a period of time. And as Dr. Rai was just mentioning, there are two things which are important. We all understand that mechanical access and a balance. These two things are most important as far as TKR is concerned for the outcome. Just a second. And functional outcome and the longevity. So these two things are basic and it will never change. Whatever technique or whatever technology you use, these things will remain. And in last almost 25 years of experience of total knee replacement, I must say, and this is my experience, and this is the experience of the majority of the surgeons, that in majority of the patients, you are able to achieve these targets and you are able to align your joint well and provide our patient a very stable joint which is functioning well. So that is not the problem. But then why at all you are aspiring to use anything or to do anything? Because if you see the literature and our criteria of acceptability of outcome of the total knee replacement, at least 27% patients, they are outlining those criteria. I'm talking about immediate result. I'm talking about long-term results. And as high as 30% patient, they are not satisfied with the outcome. The reason can be varied. We'll discuss that. There are certain post-operative complications. We have been able to reduce the complication over a period of time with our better understanding of the surgery as well as the better technique. But still those complications there and those needs to be worked on. And painful post-op rehab. The pain management is also a consideration whenever we are talking about these surgeries, which are lifestyle surgeries, and these are not trauma or life-saving surgeries. Another thing is we have been able to increase the longevity of the implants by better materials, better designing, and a better aligned joint. But we need to do further so that we can provide a further longevity to these implants. Why at all? Just try to understand that why some patients are not happy or why certain patients, they are not falling in our criteria of acceptability, because every patient has a varied anatomy and different mechanical access, and that leads to fallacy in the mechanical access, which ultimately we are providing. Suppose we are cutting at a 5 degree and patient might have a 14 degree of femoral varus or valgus or whatever. So we are not able to match to that extent. Femoral rotation is a very tricky subject. In conventional surgery, we are going by convention, 3 degree, 4 degree, 5 degree on our assumption. We are not knowing the actual femoral rotation of the patient, and that is a problem. Patellofemoral joint is one area which is very difficult to correct, place your joint in the native position, because either you are correcting the posterior condylar offset or you are correcting the anterior patellofemoral groove. Both the things are very difficult to manage when you are talking about the conventional surgery. Hence, the patellofemoral tension is not being controlled, and that is why 30% of the patient, they have anterior pain, which is persisting for a very long time and may persist forever. That's a data which shows. Because patellofemoral joint, we address at the last. Mid-range stability, we are talking about the extension gap, flexion gap, but in mid-range, what is happening to the joint? What is the ligament tension? It's almost impossible to assess. So that is one area which needs to be worked on. And as I said, the posterior condylar offset, if you don't restore the posterior condylar offset well, then flexion strength or the strength or patient getting up from the chair or strength in the flex posture is not that good. So that is one thing which need to be worked. So we need a better alignment for long-term survivorship. Everybody understand more than 3 degree of varus and valgus placement will lead to early failure. That is long-term studies have shown. We need better stability in full range, not in only flexion and extension, but mid-range also, so that that provides a better feel to the patient and your joint is functioning in a better way. Then, as far as femoral rotation is concerned, we need to provide patient's own natural rotation. That's more important. A functional rotation of the patient, and that is what is need to be worked on. We are always talking about anatomical rotation, but here we are talking about a functional rotation. If we can reduce the pain, that is always welcome. Reduce the blood loss, always welcome. And try to reduce the post-operative complication related to the medullary handling. All these things will lead to a faster recovery and more satisfied patient. That is my outlook. If you see the data, the computer devices are there for more than 25 years now, and people have used them, and people have been able to provide better outcome, no doubt about it, as far as mechanical access is concerned. As far as medial-lateral stability is concerned, even your navigated joints, they have been able to provide you a better outcome. That is clearly showing in registries and data. From 79 to 80%, we have been able to reach to 95, 96% of corrected alignment in patients. And that is the reason, world over, majority of the countries, they are increasing use of some of the other computer device for the better surgical outcome. I'll just comment one thing, what Dr. Rai was telling, that the Sweden and the UK, these are the two countries who are the least in this. They have been lowest to adapt to these technologies, and reasons are varied. That can be discussed in a separate issue. But Australia and New Zealand has been on the top, as high as 33% of the surgeries in Australia, they are done by some of the other computer device. Coming to what are these computer assisted devices, right? They can be divided into three categories. One is your passive system. The common example of passive system would be our navigations, in which there's a screen. It gives you certain feedbacks regarding alignment, regarding your rotation and all the data. And the surgeon is acting according to that, using a guided cutting systems and a guided tensioning systems. So that is what passive system is. Then there are semi-active system. Semi-active system means there is a robotic arm which is providing you control over the cut, over the placement of the implant, in which axis or rotation you are placing. But that arm is controlled by the surgeon. Surgeon is moving that, and it is in keeping surgeon in a safe limit. This is the axis, this is the rotation, and it will not allow you to go beyond that. So that is your semi-active systems. Then there is an active robotic system. Active means it's a robotic arm which works independently, and as soon as you switch it on, it will do all the cuts on its own and give you the desired results. The active system, active robotic system, was the first system which was designed. That's the RoboDoc, and it was designed in 1990 and 92. It was used in US. So it's nothing new, but now we have improved it and we have a better technology available with us. There's other classification which has been used. They are image-led system. That means there's no pre-operative images created in the software, and you right away go in the surgery and you map the patient's bone, and then a model is created on which you do all your calculations, like your Cori, Velis, and ROSA system. Then there's image-based systems like Kavis and Mako. There is a CT image created, and that is fed into the software, and you do all the planning and everything on that software, and then you go to the surgery and do the mapping and registration, and you proceed as we do it in an imageless system. So these are the two systems available, and till date, I think both the systems, they work well. It depends on surgeon and choice and their interest. I'll just go through shortly about the process, what is being done. I'll be talking about the image-based system, how it works. You just remove the first part, that is imaging and software planning, and then it becomes an imageless system. So first two stages are not there in imageless system. So you take the CT scan, you feed that data into the software, and you do all the planning on that software. Whatever planning has to be done, we'll discuss it later. Once you are happy with the plan, you feed that data into robot, you activate the robot, you go for the surgery, you do the exposure, you do the registration part. That is, you are basically correlating patient's body, you are teaching patient's body to the robot, that what part is there, which part is where. So once this registration is done, then robot can understand what all is there. And in image-based system, that image you have inserted before, it creates a 3D model of the patient bone. And in an image-less system, it will create a morphed image based on that's an animated bone based on your registration process. So both will create an image, and on that image you are working then. Once the registration is done, then you try to understand what will be the final gap check once you have done your cuts. You have not done any cut, you have not done anything, but on your imagination, whatever cuts you have taken virtually, those will be reflected there, and as per those cuts, it will show you what kind of gaps we are finally going to get, and what kind of tension on the medial and lateral side we are going to get, what kind of range of motion we are going to get, what kind of alignment and everything you are going to get. So everything you know before you have taken any cuts. And once you are happy that you are happy with the final result, you can manipulate these cuts at this stage before cutting. And once you feel that now you have reached your final destination, then you can start the process for going the next level, and that taking the bone cuts. This is how a plan sheet will be looking. You are doing the same thing what you are doing in conventional surgery. You are marking the center of the head of the femur. You are marking all the points on the femur, distal, medial, lateral, and then you are taking a virtual trial. This is the green color. This is a virtual femur trial which has been put, and you can just see how your implant is going to be seated finally. How my tibia is going to be seated. In the AP view, how it will come. How much bone I'm going to remove. How much bone will be left, which needs to be removed later. In all the views, I can check how my implant is going to. And this is what I was talking. The patellar groove can be matched so well, and then accordingly you can set the posterior condylar offset, and that's the beauty of this system. So that gives a better patellofemoral joint placement and can give a better strength to the quadriceps mechanism and lesser anterior pain. You can see virtually all around how your implant is going to be placed, and how I know that this posterior medial bone is extra there. That will be leading to some laxity on the posterior medial side, and that I can compensate in my plan. So all these you can do before you have entered into the OT. And likewise on the femur side, you can see all around how your femur implant is going to be seated, whether there's any notching or not. And this extra bone again posterior medial. If it is a varus knee, so I know I am going to remove this and to correct the posterior medial tightness. This is how the final placement will be there. And once it is done, then you have to put your trackers. Trackers are the device which is connecting the robo to the patient's limb. You put two trackers, one on the tibial side, other on the femur side. I prefer to put a femur tracker on the wound itself. I don't put a supracondylar pin. That increases the chance of fracture, so I avoid that. And then a diaphysial pin on the tibial side, and that completes my placement. Once your tracker is placed and your robo is reading that, then we go for registration. From here onward, the process of imageless and image-based system remains the same. You place the tracker and then you do the registration. And registration, you are actually guiding the robot. Where are these different bony points of the patient? So all the points has to be marked so that the robot can understand better what is the patient's anatomy, right? And here I'm seeing on the screen in front of me and placing different points with my probe. Once you have done the registration, now you do the gap check. The gap check, sorry. Yeah. It will open a screen for gap check in which in flexion, extension, in all the positions, what will be your final gap once you have taken whatever cuts you have decided on your software, right? And you can manipulate each of them as per your requirement, whatever is needed. And once you are happy, you open the initial planning, see the gaps, you can shift your femur, you can rotate your femur, you can shift your tibia, you can do whatever you feel like to get the proper alignment and a proper stability. And then once you have finally agreed that this is the alignment which I'm going to accept, this is the stability I'm going to accept, you save it, and then the role of the robo comes. This is the screen which I'll just share. Just focus on these numbers in the lower right corner. This is an just neutral view of the screen showing you different things. The rotation of the femur, varus valgus of the femur, flexion, extension, how much it is you have created for the implant, femur implant, how much bone you are going to resect on the medial side, on the lateral side, how much tibia you are going to resect on both the sides. -5 means there is a defect on the medial side, and +3 is the 3 mm resection, bony resection you are going to do. And you add cartilage to this, there will be approximately 4 to 5 millimeter of cartilage on the lateral side. So practically you are resecting 8 millimeters here. So this is a gap check screen which is visible. And then we do a varus and valgus stress. When we do varus stress, it is showing 13, and you can see here max it is showing 14. That at certain point it is going up to 14 millimeter. And on the medial side it is 9 millimeter. That is the mediolateral discrepancy is almost 5 millimeter. That we need to address because we need a balance knee. Likewise, we put in a valgus stress, and then it is showing 8 here and 9 here max, you can say. So 9 and 14 is my extension gaps. Come to flexion, and again the varus stress or interrotation stress. It is showing 10 millimeter on the lateral side and 3 on the medial side. That means there's a difference of 7 millimeter. So we have to correct this now. The first thing is the 14 millimeter of extension gap is not acceptable to us. We prefer to go for either a 9, 10 or 11. We don't want to change that, and we want to keep the joint line in the correct place. We don't want to elevate it just by putting in a thicker spacer and removing more bone. So we have to correct this first. And what we do, so this is how it is visible. And you look here, D 3 mm. What I did, 3 millimeter, I have distalized the femur. The femur has been shifted distally for 3 millimeter, and then I'm able to create a 11 millimeter of gap on the lateral side in extension. So that is first thing which I have achieved. Now, there's a difference of 5 millimeter and difference of 5 millimeter here. You can see. Now we'll try to balance the flexion gap. So what you do, sorry, I'll try to first balance the mediolateral discrepancy. The mediolateral discrepancy is there in both extension and flexion. So as a joint surgeon, we all understand that if there's a discrepancy both ways, you have to work on the tibia. That is one thing. And since it's a mediolateral discrepancy, a 3 degree of varus is acceptable on the tibial side as far as stability and overall mechanical axis is concerned. So that is my limit. So I can put my tibia into 3 degree of varus. So now you can see here, it has been put in 3 degree of varus. So once you put in 3 degree of varus, automatically medial tightening is gone and your knee is perfectly balanced. 10-10 in all the quadrants, right? In flexion, extension, everything. And We have not captured in the mid flexion because our software, they don't allow you to capture your image in mid flexion, but it gives you a screen view that you are moving your knee into the full range and what is the balance. So it is balanced right from extension to flexion. Usually with flexion, we keep it in 90 degrees. And here it is giving you that it is 5 degree of varus, that is 3 degree of varus on the femur tibial side, and 2 degree varus, which I have previously taken on the femur side. So if you talk about the varus placement of mechanical axis, the 5 degree is the limit which is acceptable today as far as the mechanical axis is concerned in robotic field. Certain surgeons, they are using more. If they say if it is in more varus, but your knee is stable, bone quality is good, it won't harm. But my limit is 5 degrees. So that's what I have taken, and I've been able to achieve a 100% balanced knee with this gap. And likewise in flexion, it's the same. Once you have achieved that, you are happy that this is the final configuration what you'll be needing or you'll be giving, you let the robo go, and it's a bar, like 6 millimeter bar, which will be controlled by a robotic arm. As soon as you switch it on, the femur mode, it will cut the femur, all the cuts, starting with the distal femur, then chamfers, then anterior, then posterior. And once all the cuts are done, you can do a trial femur and monitor it on the screen, and you can put your final implant as we do it in regular surgery, regular cemented placements. So that is how it is being done. The advantage, what I feel is that even before surgery, I can plan everything. I go with a very clear mind what I'm going to do. I don't have to fiddle around. I know the patient's anatomy since I have done a CT scan, any bony defect, any severe deformity, any kind of extra bone gaps or defects or extra bone which needs to be removed. I can understand everything, and I can place my implant in a perfect position, which as far as that patient is concerned. And even that planning, I can change at any point of time during the surgery before I have started the cuts. And once I have done the cuts, I can recheck that what I have planned is working and I am going in a way which I wanted to go. It gives you control at every point, and it gives you feedback and outcome better every time. That's the important thing. What literature has suggested till now, whatever studies are there's lesser blood loss. Definitely, since you are not violating the medullary canal, the chances of related to your pulmonary phenomena are not there. And definitely lesser post-operative pain and better knee control. I think the reason would be since we are using just a 8 millimeter, 6 or 8 millimeter bar, and you are not retracting those tissues beyond certain limit. You are just putting your retractors and letting your bar go between the window and cutting everything. Soft tissue dissection is relatively less. Definitely, it increases the operating time, and still, if you talk about the conventional surgery and this, approximately 15 millimeter extra we are taking to perform a robotic TKR. I think that's good enough if we get a better outcome. Hence, the recovery is faster. We are conducting a study on this, the pain protocol and pain tolerance in the patients, as well as the post-op rehab recovery by independent observers like physiotherapists and the pain management team separately from surgeon's team. And let's see what outcome it gives. But overall, the impression is it definitely gives it. And since we are providing better stability and better alignment, and the knee is conforming to the patient's own anatomy in a better way, we expect that it should be performing better and it should give a longer life to the implant. Okay. Thank you.
Right on this topic. Now I'd like to invite Dr. Akhilesh Yadav, sir. He is a renowned knee replacement surgeon. He is a Ranawat Fellow. He has done fellowships from USA, Germany, and Mumbai. And currently, he is a director and unit head, Max Hospital, Vaishall. And now I request Dr. Akhilesh Yadav, sir, to please share your presentation. Thank you.
Meanwhile, we can ask the questions. Imran, if you
okay,
allow.
sir. Okay, sir. 1-2 questions, please.
One question for Dr. Sanjay. Lucid presentation was excellent, knowledgeable. My one question for this robotic indication in a revision surgery, is it in a process or it is just for going primary?
Right now, revision is not available as far as my knowledge for robotic surgery is concerned. It is not.
Is it in the process or it is?
It is very much there, because that is one area where we want more help from
because that will add on more rather in a primary, because primary is more or less we are very much adjusted with the conventional.
That's what presentation was.
Exactly.
But actually, it is not happening. But we have resources.
Because that in a revision surgery, just breaking your voice.
Yeah, sure.
Yeah.
Dr. Akhilesh is muted, I think.
He's muted.
All right. Now, okay.
Yeah.
Hello.
Yes, we can.
Okay. So, good evening to all of you. Thank you very much, Imran and Dr. Santosh, sir, to invite me here to speak about my experience. I think it is 17 years experience in conventional total knee replacement. So, as we are all doing this total knee replacement with the conventional method for a long time, and you know that after a time, this is a simple thing. I mean, this is I can say very simple surgery when you are doing a large number of total knee replacement. Conventional TKR introduced in 1968, and since then the basic things never changed, and that's why it's not moving. Oh yes. So as we know that it is a very successful, effective, and satisfaction surgery. And nowadays, this is the recent news from the Times of India in 2023 about more than 2.5 lakhs total knee replacement done in India per year. So that is because we are giving the excellent results and having good patient satisfaction and increasing the disease burden in the society, increasing the awareness of the total knee replacement and its success in the society, and no doubt increasing the insurance holders, increasing surgeons, and now Ayushman Bharat. So all total, the number of surgeries are increasing day by day. So we know that from the very beginning, it was conventional, then came the navigation, it started in 1997, but the robotic surgery was started in UK first in 1988. So conventional, the conventional surgery is, in my view, very simple. And we have to achieve the basic goals, appropriate balanced and symmetric flexion extension gaps. So whether you are cutting in varus or valgus, you need a balance and symmetric flexion and extension gap, as very well said and explained by Dr. Sanjay sir. And second thing, mechanical alignment should be achieved in a correct method, and we have to preserve the joint length. So these are the basic things which is not going to change. Dr. Sanjay Srivastava also gave a more emphasis on that. So failure to achieve the primary goals, no doubt. The most important is patient dissatisfaction, whether in terms of the pain, limited range of motion, or accelerate the component wear. So this is the simple case, and the planning is no doubt for most important, whether you are going with the conventional or the any robotic or navigation assisted. So this is the simple case, and it can be done very quickly. Operation time would be around 19 minutes to 25 minutes. So what with the time I learn and now I do in this limited time period. So the exposure is less, and if we concerned about the alignment, so no doubt if you are planned very well preoperatively, and if you balance the knee, so there is no problem. So no extra and heavy machines in the OR, no extra charges for the machine, no extra time for the preparing the robot, less consumption of the OR time, less operating time, and less traffic in the operation theater. And the robotic, as Dr. Sanjay Srivastava sir has explained about it, that patient has a minimal pain. So how? I mean, we are cutting the skin, fascia, muscles, tendon, and bone. So pain is totally dependent on the post-op pain control protocol. I think by the robotic surgery, the pain cannot be minimized. It's and second thing is minimal blood loss. No doubt, if you are not this encroaching the medullary canal, so blood loss would be less. And bone loss, minimum bone loss, I don't think so, because we are cutting to the appropriate amount of bone, 9 mm, 8 mm, which is decided by the preoperative planning or in the intraoperative period, and better alignment of the joint. So again, if preoperatively you have planned very well, in conventional TKR, you can get good alignment and good this extension gap and good range of motion. Better component accuracy. So there may be error if the surgeon is experienced. So I think that is enough if is doing conventional or robotic. Increasing lifespan of the joint, no doubt, if your knee is totally balanced and in a good mechanical axis, whether you are doing with the conventional or robotic, you will definitely have a increased lifespan of the implant. Walking within hours of surgery. So this is little bit amazing and surprising. If the patient is going through the robotic surgery, so he can walk very fast. So I think it's totally depend upon the post-op pain management and faster recovery time. It's totally depend upon the pain control mechanism. And if suppose there is some literature also says that with the robotic there is less soft tissue injury. Why? You are opening the things up to the sufficient exposure so that your robot can work. And similarly, in conventional TKR, with the time you definitely give a small incision, you respect the soft tissues. So again, the soft tissue injury is less. So there are many literatures, many papers I have gone through. First, I have gone through with the navigation versus conventional TKR. And there, on the PubMed, I have seen many articles, and conclusion was no significant difference were found at long-term follow-up in terms of radiological clinical outcome or implant survival between the total knee without navigation or with navigation. Again, though there are some papers I have gone through robotic versus conventional total knee replacements. So this is the, I think, recent one in 2023. So again, this study says no statistical significance was found regarding pain and function at all stages post-operatively. Conclusion, there was no short-term difference between the robotic and conventional TKR regarding pain and functional outcome. So there is a need for the further extensive research on the robotic TKR. Again, this is the paper which is showing complications and downside of the total knee replacement with the robot. So there was, complications of the robotic system were pinhole fractures, infection, iatrogenic bone injury, which can be also in the conventional, and excessive blood loss. There was, they have written this thing on that. So a longer operative duration, higher intraoperative, learning curve, and sometime in between robot can be abort because of the software, malfunction or something. So these were the literature I have mentioned. And again, there is a systemic review regarding the robotic technology in total replacements. So they have shown that the limitations are there. Limitations is the installation cost, additional radiation exposure, learning curves, and the compatibility of the robotic technology with a limited number of implant design. Yes. So if you are having a particular robot, you can use that particular company's implant, no other implant you can use. If you are going to use, then you can, cut only the distal and distal femur and the proximal tibia. But if you are using the other company, so you are not going to use it fully. Further, high quality studies are required to compare the difference in conventional TKR and the robotic. So these are the literature which are showing that there is no significant difference, and in the recent in the short term period there is no significant difference. And cases like this we are doing with the conventional. These, if we are using the Merrill robot, so if there is a bone loss, so you can't get the bone for the building the medial condyle or the bone defects. So this is a very big drawback in these kind of cases where the half condyle is totally gone, and sometimes you have to need the bone to reconstruct the medial condyle, and you have to see you can't mark the landmark during the registration on the operation table for the registration during total knee replacement, and see these kind of X-ray. So this is very difficult to recognize the landmark and difficult for the robotic cases, I think. So see, this is some example intraoperative pictures. We can see there is total medial condyle bone loss, no bone at all. So we have reconstructed with the bone graft, and the other knee, right knee, is half of the medial tibial condyle has gone. So we have to go for the augment. So here we have to take the step cut. So the basic thing is basic principles would always be the same, and machines cannot be replaced the surgeons and their experience. Men would always be on the driving seat. So proper pre-op assessment and planning is all very necessary in the conventional TKR, and basic principle never change. Should have proper idea and knowledge about the implant and instruments of the company you're using. Conventional TKR is cheap and quicker, no pin tract infection or infection, less OR traffic and less instrument in the OR, no long-term learning curve, and always keep extension rods and 3.5 is doing the set in the operation theater. Thank you very much.
Thank you, Dr. Akhilesh Yadav, sir, for this nice presentation. And I request all the listeners to please ask questions in the chat box. Now, please unshare the screen, Dr. Akhilesh Yadav, sir. And now I'd like to invite Dr. Amit Jaiswal from Varanasi. Dr. Amit Jaiswal is a senior robotic joint replacement surgeon. He has done his fellowship from Germany, and he is currently director Orthomax Hospital, Oriana Hospital, Varanasi, and Asclepius Hospital, Noida. And he is currently president of Varanasi Orthopedic Association. So I welcome Dr. Amit Jaiswal, and please start your presentation. Thank you.
Good evening, everyone. Dr. Imran, thank you very much for your nice introduction. I would like to thank UPOA Orthopedic Association for giving me this opportunity. Today, I'll speak about the robotic TKR, my life experiences. To start with, I will start with a simple case. She is a 77-year-old female with pain in her both knees. She had a severe varus and FFD in her left knee. So, with the help of walker, 2 assistant, and braces on her both knee, she was merely able to walk properly. So it's now clear that it's a complex primary case where there is a varus deformity of around 35 degree. This 35 degree is basically anatomical, not mechanical. If we'll add on 5 degree or 6 degree, it will become around 40 to 41 degree of mechanical varus and fixed flexion deformity of around 10 degrees. So it's a basically complex primary varus. In such type of cases, we know that surgical challenges are restoration of mechanical axis, soft tissue balancing, and use of minimal constrained implant. So which implant should we use in such type of cases? Should we go with this conventional implant or should we go with the TC3? How much tibia cut, how much femoral cut and medial release should be done is a question. So in such type of cases, in tibial cut, we should always remember that we should cut the tibia less. Otherwise, there will be a big gap between the extension and flexion. And it is always advisable to do an extensive medial release. But how much release should be done, it is not defined. If we'll release 1 mm, 2 mm, 10 mm, this release will give how much opening on medial side is not defined. On table. Remove the osteophyte, it is always advisable, and sometimes you may require to downsize the tibia and lateralize the tibial component to correct wedge. And many times you may require the epigonal osteotomy in such type of cases. In femoral cut, again, cut the femur less, but how much less is not defined. Cut the femur less. Our conventional method systems give us opportunity to cut either 9 mm or -2 or -4. That doesn't give liberty to cut -1, -1.5, -0.5. Valgus angle of the distal femoral cut should always be less. If we cut the femur in more and more valgus, there will be more and more opening on the lateral side and will be less opening on the medial side. So if you cut the valgus in a conventional 7 or 6 degree valgus, you may land up with a complication with overzealous release on the medial side. So I did this case with the Vaishall robotic system, which has a base station, robotic arm, and satellite station. It's basically a real-time navigation with robotic arm. So this was my initial leg alignment before all cuts. I had opened the joint, and this was my initial leg alignment. On lateral side, it was already 10.5 and 10.5 in both flexion and extension. And on medial side, it was 3 and -2.5. It was around 26 degree varus. That is basically anatomical varus. So it was basically medially tight. Once I did the soft tissue medial release and remove all the osteophyte, I could achieve 3 mm more. So still on medial side, it is 0 and 6 mm. 0 mm in extension and 6 mm in flexion. This was my opening. So during the intraoperative planning, I had to accept the 2 degree femoral component varus. I had actually rotated the femur from 3 degree to 5 degree to close the lateral opening, both in flexion as well as in extension. And because there was a little bit mismatch between the flexion and extension gap, from 3 degree flexion to I had flexed the femoral component to 5 degree. So this was my leg alignment. With this alignment, I could able to balance the knee properly. So my final acceptance was tibia cut 1 degree varus, downsize and lateralize the tibia, femoral cut 2 degree mechanical varus, and femur in 5 degree external rotation. So this was my final alignment before putting the implant. So this was the post-operative X-ray. You all can see that there is a 6 mm insert I had used in this case. because we people know that if you are doing it in a conventional method, we may have to put a 7 mm, 8 mm, or 10 mm insert in such a difficult situation. So the second post-operative day, patient was allowed to stand with the help of walker. So coming to the robotic part, robotics for knee replacement surgery. During the surgery, we put the 2 pins in the distal femur and 2 pins in the proximal tibia. As trackers with these 2 pins. Now after putting the trackers, we registered the distal femur, center of the femur, right sides line, anterior cortex of the femur, medial and lateral femoral condyle, and posteromedial and posterolateral femoral condyle. Then we register the proximal tibia, medial condyle, center, lateral condyle, and sagittal axis of the tibia. Then we register the medial and lateral malleolus. After this registration, we check the equivalence graph. We flex and extend the knee, and we check how much medial and lateral opening is occurring during the surgery. So this graph helps us and give us idea how much opening is there, how much correction we have to do. This robot is basically a 4th generation robot, which is a compact and table mounted. It is a saw-based system, and it is a basically 4th generation robot with real-time navigation inbuilt. We don't require any CT scan before the surgery. So, and this intraoperative planning screen, it's a very, very useful screen where we can accept 1 degree, 2 degree rotation, flexion. We can change the femoral component accordingly to have a better stable knee and better aligned knee. So it's a real-time based. This is a sensor tensioner which comes with this robotic system. This is a beautiful device. In conventional knee, we check the flexion and extension gap in a 0 degree and 90 degree only. We don't check the gaps at 30 degree, 60 degree, 120 degree, or 110 degree. In this surgery, we cut the proximal tibia and put the sensor tensioner in between the gap. After putting the sensor tensioner, we can flex and extend the knee, and we can check how much opening is there in medial side and lateral side at different angles. At each and every angle, you can see how much opening is there and how much mismatch or imbalance is there. This robotic system works like a guided missile. Suppose your assistant moves the tibia front or back, that robotic arm moves in the same plane and it cuts in the same plane. In this situation, I'm moving the tibia front and back, and that robotic arm is moving according to that tibia. So it is always under the surgeon's control. It is an autopilot, but always under the control of the pilot. These are my few post-operative X-ray, AP, and lateral. Coming to the literature part, in the Journal of Orthoplasty, you can see that this article says that image-free robotic assisted total knee orthoplasty improves implant alignment accuracy in a cadaveric study. And this was the publication in JBJS on robotic assisted total knee orthoplasty. They say that this system improves the accuracy and precision compared to the conventional TKR. Robotic assisted TKR is significantly more accurate and precise in the planning and component positioning and final polyethylene insert. Another article published in JBJS by Kayani et al. It was basically a prospective randomized control trial. They say that robotic TKR was associated with decreased iatrogenic injury, reduced femoral and tibial bone trauma, and improves component positioning compared with the conventional TKR. Another article published in JBJS in 2018. It is basically a prospective cohort study. They say that robotic arm-assisted total knee orthoplasty is associated with improved early functional recovery and reduced time to hospital discharge compared with conventional jig-based system. Another article published in 2018 in Journal of Orthoplasty on robotic assisted total knee orthoplasty. They say that advantage of robotic assisted TKR may include greater component accuracy and precision, soft tissue protection, and increased patient satisfaction. Another article published in Journal of Knee Surgery in 2021. They say that there is a significant improvement in the patient satisfaction was demonstrated compared with the TKA using conventional jig system. Robotic assisted surgery provides several advantages in TKR, including real-time information in millimeters to help obtain balance gap, accurate bone cut, and reduce soft tissue injury. Another meta-analysis published in 2022, just 2 years back, they said that robotic assisted TKR resulted in better better knee society score compared to mechanical TKR or conventional TKR in a short-term and mid-term follow-up, and they demonstrated improved accuracy compared to the component positioning and patient-reported outcome. So coming to the take-home message, robotic TKR gives a improved accuracy of component placement. It gives better alignment of the knee. It gives better outcome in terms of less post-operative pain and early rehab. It reduces the time to hospital discharge and is very, very much useful in a complex primary situation and extra articular deformities where you cannot put the intermediate rod in the femur. So these are the extra advantages. With these words, I would like to thank you all for patient listening.
Thank you, Dr. Amit Jaiswal. And I'd like to ask some questions. First of all, for the robotic surgeons, I would like to ask question with Dr. Sanjay Srivastava and Dr. Amit Jaiswal. That if a patient had said that what assurance you want to give me regarding post-op pain and blood loss and bone loss and accuracy and the post-op recovery, what he sees on the internet and all that. What actual assurance you give in your OPD and what in the post-op you face, what questions you face. So what assurance you give and what you face in the actual post-op period?
Assurance has to be realistic. There's no confusion about it. Normally what I tell them that it gives me a better alignment. That is no doubt about it. It gives me a better assurance that whatever mediolateral gap check I'm doing conventional method, I'm able to verify that. I'm able to put it more accurate. So these are the two things I assure. And I tell them that as far as past history and literature suggests that there should be a lesser pain, lesser blood loss, lesser post-operatively pulmonary complications, and better feel of the joint and better long-term outcome. It should, not it will, it should give that. So that is what has to be. I never tell them this is the only way to do it. We have been doing it for years, conventional method, and we are happy. So that's how I give them option. Majority of people, to my surprise, I don't tell them robotic. They want robotic. Maybe it's marketing, internet, and whatever. They come for robotic. So that's.
Can I ask some question?
Yeah, sure.
My question is to Dr. Amit first.
Yes, sir.
Do you do all your cases with robots or only selected cases of your patients?
Sir, right now I'm doing mostly more than 95% of cases with robotics only, because I am very much comfortable with the robotic system, what I am using for past 11 months. For revision cases, we don't have any option. We do free-hand surgery. And Ayushman Bharat cases, a patient cannot afford. Those we are doing with the conventional method. But practically more than 95% patients, I am doing robotic for past 11 months.
That's what I come to know, that like the valley surgeon are doing all their cases with robot, but the QV surgeons are doing only 10 or 20% cases with robot. So question is to Dr. Sanjay Srivastava. Why are you doing only 10 or 20% of your cases with robot, not the all the cases?
Definitely, you have to cater to the patient, because patient is going to bear the extra costs. It's almost 50,000 what disposable cost we are charging from the patient. If patient is not ready to bear that, how can you do that? And most of my patients, they are referred from the patients for last 30 years of practice, whatever TKRs we have done, they are satisfied patient, they send them, they come for TKR. We give them option. If most of the patient where they are able to sustain that amount, 50,000 amount they want to spend, it's fine. Many of the patients, they say, you did that patient, he or she is doing absolutely fine. So why should I pay extra for that? So it's patient choice. You cannot impose.
I don't agree to this, because once you are convinced that you are going to, with robot, you are going to give much superior results, much better outcomes to the patient. So if you are not giving the same kind of services to your 80% of the patients, so I don't think you are doing justice for those patients. If you are convinced you are doing better, giving better results.
Definitely. We are using higher end implants also. We are using lower end implants also, depending on the patient's pocket. Because the patient is not able to afford, I can't tell them, you go back, I'm not going to operate on you. We are doing almost 70, 80 joints in a month, but hardly 20 joints we are doing robotic. Because that's patient choice. You can't do that. You can't do that.
Okay. Number two,
I definitely tell them it's a technology, I believe, and it should give a benefit. That's it.
Technology is going to persist. There is no doubt about it. But with robot and with conventional thing, there are so many confusions prevailing in our fraternity. Yeah. There are so many alignments. Each and every surgeon is having their own alignments. So there are 9 alignments there, and each surgeon is like propagating on their own alignment. I just want to ask you one question. How much balancing or soft tissue release do you do in your cases with robots?
With robot, in very severely deformed cases, we do, but in mild to moderate cases, we don't do any releases. That's why they are less painful. Secondly, I'll just answer a question which was discussed before. Why it is less painful? Because in robotic surgery, you are doing less releases. That is first thing. Cuts are the same, but periarticular releases are less. First thing. Secondly, you are not dislocating the knee. You are not keeping your tissues retracted to a maximum extent for a longer time. So all these things, they generate pain. So that's why that is the assumption that's why it should be less painful. Secondly, somebody was mentioning that pain should be due to the pain management. But the thing is, pain management is same whether we are doing a conventional, whether we are doing pain management remains the same. Pain team remains the same. We have an excellent pain management team, and our patient, they are up and mobile. A patient is happy enough in 6 hours time post-op, even in convention, even in robotic. So we are just trying to analyze that whether robotic patient, they are giving a better outcome or not. We are, but as far as our experience is concerned, we are not out with the verdict. But what we are talking about is what literature is saying, what people around the world they are having a feel of it.
One more thing I would like to add, Tomar sir. One more thing I would like to add. Something I had changed in my practice before robotics. I was doing only a unilateral surgery at single sitting, and after a certain duration, I used to do second knee because of the fear of the fat embolism that comes from the intermedullary femoral canal. So with the robotics, right now I have started doing a bilateral in a single sitting, and there is hardly 1 unit of blood transfusion is required in post-operative period. Because you are not putting the intermedullary rod, there is less chances of fat embolism and all those complications. So one extra advantage that I could see on my patients. So by doing a bilateral in a single sitting, also cut short the medications that we're using in a unilateral 2 sittings. So antibiotics and all those expenses has been reduced. That is another extra advantage I'm feeling. Bye, sir.
I don't agree with this, because with conventional also you do bilateral in much shorter time and no blood transfusion is required, and they are painless also, as Akhilesh said, with proper pain management. What is your alignment philosophy? And
sir, for routine,
functional, or what kind of alignment do you
follow? Sir, for routine, simple primary knee anatomical, and for a complex primary that I have already presented in this presentation. For complex primary restricted kinematic, we accept up to 3 degree varus in a complex varus situations, and from 3-degree flexion to 5-degree flexion in femoral component and 3 to 5-degree external rotation in the femoral component. So restricted kinematic in a complex situation, and is for simple mechanical.
And soft tissue balancing, soft tissue releases?
Soft tissue releases has been reduced, sir. A very minimal soft tissue release in a complex situation, in a complex primary. Definitely, we do the soft tissue release. Like in this case, I had to do downsizing and lateralizing the tibia as well. But for a simple primary cases, very minimal soft tissue release.
And Dr. Sanjay, what philosophy do you follow, sir?
Imran, can I say something?
Yeah, please go ahead.
Imran, can I say something?
Please, sir. Dr. Akhtar, sir, please.
The world literature overall says that maximum knee revisions are done within 5 years because of infection. In other words, within 5 years, the knee which is revised is because of infection. And over 20-25 years, it is because of malalignment. But the overall revisions are because of malalignment. If a robotic knee gives a better alignment, definitely that incidence will go down as far as the revision is concerned. But maximally, a knee replacement is a soft tissue balance. I have hardly done any cut extra in femur, even for 60-degree flexion deformity. And that has been managed by soft tissue balancing. But the reports which I gathered is that it takes longer time unless you have done more than 200 robotic TKRs. And even if you are able to do it in an hour's time, a surgeon who has done more than the 200 replacements conventionally, he will also catch the same time. Second thing, what Dr. Sanjay Srivastava said, that you have to dislocate the knee, that might give you more pain. Yes, I do. I agree with that. So overall, the results, they say that on one hand, we are opening the knee, we are doing surgery, but pin tract infection, sometimes fractures have been reported because of the pinholes, longer operative time, and stiffness. Then overall result, overall longevity of the system depends not only the malalignment, 1 or 2 degree difference does not change the scenario significantly. This is one point. Second, the longevity depends upon the daily activity of the patient, weight of the patient, how he is carrying himself in life. These all factors are there. So it is to me, I'm going to be very blunt. I think people will excuse me for that. Yes, it does give accuracy. It does give alignment. It does gives you a very nice cut, how much you have to do cutting and all that. But all those things can be managed if you have planned beforehand, preoperatively, and you have balanced the soft tissues. You can handle both those things, and that will not make a difference in the long-term surgical result. This is what I want to say. And moreover, people keep these kind of things. I'm going to be very blunt, but it is a marketing gimmick. In fact, in India, look, in England, where it was started in 1988, somebody said, still it is not a popular surgery over there. Maximum surgeries in America, in New Jersey, if somebody experts from that place should have joined this webinar to tell about the robotic versus non-robotic. It attracts, yes, the people who can afford, they will go to a surgeon who is claiming that he's a robotic surgeon. I told you more than 200, that is the data, they don't reveal it. If you have done more than 200 robotic knee replacements, your operative time, it can go to about 1 hour. But the same can be achieved by a conventional surgeon who is regularly doing a CT scan, trying to know his cuts and trying to do a soft tissue balance. Now, in India, most of the time, we have got synovitis associated. Many times we see such cases. And then you have to do a joint debrima, a joint synovectomy. All these things cannot be done. True, you have to cut, you don't have to put a rod and all that. But there are heavy patients, and where you have to use an extension rod. If you have very heavy patient, you cannot do it with a robot. So there are certain patients where you can definitely offer them, where there is an extra-articular deformity, as Dr. Jaiswal said. There it can give you a guideline to help you to make your cuts and to have a pre-hand idea before you go for surgery. You should keep the machine, no doubt, but mostly people do what they do inside. It's conventional. That is what I'm going to say. This is the scene in India.
Dr. Sanjay Srivastava, along with your comment which you are going to make right now, there is a question from the chat box. Dr. Akhilesh Yadav want to ask.
Yeah.
uh, do you experience less painkillers in robotic surgery in the patients in which you do robotic surgery? Are you using less painkillers? One and other thing that do you experience less rehabilitative time for the robotic knee replacement surgery patients?
Well, stiffness has been reported with robotic knee replacement in literature. That is from Springer. It is the Dr. C. Dagalo, cited by 22 complications of the knee, pinhole fracture, pin-related infections, iatrogenic soft tissue damage, more time consuming, and knee stiffness. So that you can say that gives you maybe less pain, but that's not a great thing for which more cost to the patient, more cost to the surgeon. Of course, it is a fashion. Now I will divide like this. The younger surgeons coming up, they have to come up and be in the competition. So they will come up and go for robotic. There's the mathematical all calculations. The middle-aged surgeons, they might go both the ways. And the old surgeons, they will again go for conventional. They are used to it and they're happy with the result. Whatever you do, 20% patients, as the literature says, are not that satisfied. 15 to 20.
That is the bottom line. Because
conventional method also patient can.
If you see the long-term literature, 30% of the patient, 30% of the patient, they are not satisfied and they don't have a desired outcome. This is my data. It is the international data and it's multi-centric data in which all the surgeons who have done participated in the study, they are well experienced. They have done thousands and thousands of cases. So because we don't analyze our cases in that critically, we don't know. We accept everything. My patient is doing fine because patient don't come back to me. My patient is doing fine. I don't know whether it is doing fine or not. So we are talking about improving on that point, that if we can improve the alignment to that, if we can improve the patient satisfaction, that will be my ultimate objective. Secondly, as far as pain management is concerned, it might be, pain is a very subjective phenomena. In one patient has a lot of pain with a milder injury and other patient is happy. So it's very difficult to assess that. So we have to really see the data, a long-term data or a larger data, not long-term, larger data to see whether it is actually doing wonders. But whatever experience we have seen, patients are definitely more confident on walking because maybe that is the reason, because the stability is better. Secondly, what we were talking about, you can do it conventionally. Definitely, if Dr. Rai has put me in the younger surgeon group, I'm thanking him for that. Because after doing 7,000 knees, if I'm still a young surgeon, it's good to be
still a young surgeon.
It will take hours in the first few cases. It takes hours. First time
I have one comment. As Indian surgeons, Dr. Rai, as Indian surgeons, our results are 100% perfect. A single patient is unsatisfied. We never accept that our patients are unsatisfied. Here with robotics and conventional, the difference, I have been doing knee replacement for 30 years. The first I had done in 1994. Pretty happy with this. The only problem coming to this is that the alignment philosophy. Alignment, like with conventional techniques, we do mechanical alignment. With robotic, we go for anatomic and various other alignments. Recently, when I was in a conference, one of my friend is doing, like, he has three robots, a younger orthopedic surgeon. So he was doing live surgeries. I was there for 2-3 days. And there 9 surgeons were 9 different alignment philosophies. All surgeons who have come just in 2 years, they have done 500 surgeries, 400 surgeries, and everybody is claiming this is the best. And few of them went to the varus alignment to 7 degrees also, 7 degrees varus alignment. Internal rotation of 4 degrees also of the femoral component. And they were not touching. Some of them were saying they don't touch the medial collateral ligament, no zero balancing. Whatever deformity has to be corrected with bony cuts only. This alignment, the tibial angle, can go haywire. Like if in conventional technique, that you see your angle is going varus, say 2 degrees acceptable, 3 degrees acceptable. Of course, with conventional techniques, we can do 2 degrees exactly, maybe go 3 degrees. So you can be less than 3 degrees, but they were accepting even 7 degrees of varus. No release at all. That medial soft tissue has to remain sacrosanct. Don't touch it at all. Your say of Dr. Amit and Dr. Sanjay.
The thing is, what we are talking about, that those 30% group, we all have seen that we have done a wonderful job. As far as my surgical skill are concerned, my surgical outcome is concerned, I personally feel I have done wonderful job. I have given a mechanical axis alignment. My knee is stable, but still patient outcome is not that good. Now, recently, people have given so many different alignment philosophies, as you have already mentioned. But the recent most is your CPAC classification, what people have come up now, that there are 9 different varieties of knee actually. And now people are talking about that you identify the CPAC type, and the same CPAC type has to be converted in the post-op. What patient was pre-op, then only patient will be happy. I don't know, but this is a recent thing, and it's getting very popular. What CPAC classification wise patient is in which category, and then in post-operatively, if we have changed that CPAC type, patient will not be satisfied. So the things are changing because there are certain problems. If you just overlook that problem, it's okay. But you have to address to that problem.
Yeah,
we're talking about a small percentage. We are not saying that conventional is not working. It is working in 70% of the occasion. But I don't know in what 30% is not working. I want to identify that and correct that.
Amit,
right.
your take.
In my presentation, I have already mentioned that there should be always a human pilot behind the autopilot. So if someone is doing accepting 7 degree varus, 8 degree, 9 degree varus on table, I don't think it's a right alignment strategy is following, according to me. But we should always see and check the gap balance with the help of robotics, with the help of navigation, how much we are satisfied with the balance. Up to certain extent, up to 3 degree varus, up to 5 degree external rotation, we can accept in difficult situations. That will give us a better alignment in our patients. Sanjay sir.
What I was saying that, as mentioned by Dr. Rai, that a younger surgeon, this is not a tool for a younger surgeon. You must understand the philosophy of TKR, how to balance it. If you are not experienced enough to do a conventional TKR, you will be doing blunders with a robotic. Robot is not there to guide you. It is your assistant. You should have your mind into it, and then only you can give a problem. Secondly, what Dr. Amit is saying about the varus and valgus placement of different components, and Dr. Thomar was also mentioning that. The thing is, because the pre-operative, the patient has been with that alignment for years and it was working. So now people have started thinking on those lines. Without robotic, it is not possible. You can't put things in 2 degree varus or 3 degree varus. So if you can't do it, you don't talk about it. In convention, I want to keep myself 0 because I know with the error of the saw or error of the cement implantation, I'll be producing a 2 degree or 3 degree error. So if I'm 0, then still I'm within Lawman limits. But if I try to put it at 3 degree, I might land up with 6 degrees of varus. So I can't do that. So if with conventional, I'll follow one philosophy only. With robot, I can experiment and get better control and without losing chances of failure.
Exactly,
Yeah,
Sanjay sir. In a conventional
method,
as sir is saying, that in a conventional method, if you are doing a mechanical alignment in a post-operative scanogram, it will not always be 100% mechanical. It will be around 2 degree, 3 degree valgus or varus that is beyond your control on the table. And one extra thing that we can see during a conventional method, we don't see the center of the rotation of femur and center of the rotation of hip. Actually, that is already covered inside the drapes. So we assume that we are putting an intermediate rod and we are cutting that with the help of this rod, we are cutting the distal femur at 5 degrees, 6 degrees, 7 degree valgus. Actually may not be on table, but with the help of navigation, that graph, that screen tells us where is the center of rotation of hip, and how much anatomical, forget about the mechanical, how much anatomical and how much mechanical we are cutting. So at the center of the ankle also, above the drapes, we cannot assess exactly whether the center of the ankle is here or 1 millimeter, 2 millimeter medial or lateral. That is a human error. With open eye, we can do. But with the help of navigation, with the help of robotics, that part can be corrected. Sanjay sir.
Two things I want to mention. One thing is you never able to control the coronal alignment with convention. There's no confusion about it. And we all understand that if your femoral component is flexed beyond 5 degrees, it has its issues. But you can't do that because you are putting a metal rod, you are putting your jig perpendicular to it, and then you go ahead. If you just analyze, Dr. Akhilesh, your X-rays which you have posted, right knee is in, tibia is in valgus, in varus, and left femur is flexed. You just get a scanogram and try to calculate angles. It is not acceptable limit to me. It is not in the acceptable limit. Patient is doing fine. I'm totally accepting that. But this is just an X-ray you have chosen from your basket and presented. But if we try to analyze all our X-rays, there will be many such cases. Even in our cases, what we have done, many of the post-operative X-rays, I'm not happy with that. So if there is a tool which gives me more control over these things, I'll be happy to use that. If I get it for free and I can do it for free, nothing like it, but everything comes for a cost. Secondly, a very interesting thing which we did, our JCs, junior consultants, when we balance a knee, we ask them, just look at this, whether it is balanced or not. By conventional method, they do varus valgus, said, okay, sir, it is fine. And once you check it on your robot, the gap difference is almost 4 millimeter. But a 3 to 4 millimeter medial lateral gap difference. But these are 7-8 year experienced surgeons. They are not new surgeons. They have been working with me. They have worked at different places. They have enough exposure of the total knee replacement. So what we feel it is correct, I am able to quantify that I am correct. Long-term outcome, only time will tell. If we don't use it, you will never come to know.
Sir, in a conventional method, what we are accepting that its opening, lateral opening is 1 to 1.5 mm, 2 mm, it is acceptable in a complex varus situation. Right now, we see on a navigation graph, it is not actually 1 or 2 mm. That is visible by open eye is around 6 mm, 7 mm, 8 mm on the screen and on the graph.
Very well explained, very nicely explained by Dr. Sanjay and Dr. Amit. The only issue is like by CPEC classification, we have 9 different kind of alignments in various kind of population, 9, right? And with robot, we can achieve the anatomic native alignment in all those patients. That's correct. And with the conventional, we can't achieve that. We can't achieve that because we have to confine to that mechanical access. But here, so my just take on this is like, there should be a universal philosophy with robotics. Universal, what kind of alignment you have to take? We should follow that. And then in entirety, we should abort this conventional systems because we can't do with this. Conventional system, we can't do with 9 alignments. We can do only 1. That is mechanical alignment, not all the anatomical alignments.
The thing is, you cannot have a one philosophy because there is no one patient. Every patient, you
have to be patient specific.
For mechanical alignment, there is one philosophy only.
Yeah, that's true. But it's working only 70% cases, sir.
Yeah. Well, that's right. That's right.
So
how do we identify that? How do we identify that?
Number of dissatisfied patients are, sir.
CPAC classification gives you that. What is the pre-operative CPAC patient is, and I want to do that patient to bring it back to that. I don't want to bring a patient who is CPAC 2 to CPAC 4 because that will be not the patient native alignment. It's too early. But people are working on that and we are also working on that. Let's hope we'll be able to come up with something good, something better for the patient.
Yes, I think this will be the future. CPAC philosophy is the really nice one you explained.
I appreciate.
That should be the ideal, I think.
Sir, one question from chat box, sir.
Yeah.
Dr. Pal Sisodia from Gorakhpur is asking that in what situations you have encountered that you start with a robotic surgery in a patient and you switch over to a conventional surgery, that in what situations you have switched from a robotic surgery to a conventional surgery in a patient?
To me. Yeah. One patient, we switched over because there was software failure. So they were shut down, and so we have to convey to the patient's relative that robo is not working, so we are going for the convention. That is one case.
Anything other than the
Second there was a pin loosening. These were our initial 5 cases when we did. There was a pin loosening, and when we are trying to analyze, in every position, it was giving a different data. So we were really skeptical of what is happening. And then we saw that the femoral pin was loose, and then we have to resort to, because once pin is loose, dubara, you put another pin and do all the registration, that becomes a big problem. And putting 2 pinholes in the supracondylar area, I'm not very happy with that. So that are the 2 cases when we have aborted it.
Till now, I did not abort it. I did not convert it robotic to non-robotic. Luckily, though I had done around 98 cases till now, I did not find any problem while doing the robotics, and that can be overcome by non-robotic method.
One more question to Dr. Akhilesh Yadav, sir. One question from Dr. Akhilesh Yadav, sir.
Yes, Imran.
So, Dr. Akhilesh Yadav, if a patient comes to you and says to you that I want robotic surgery from you because I have seen a lot of internet and I want robotic surgery from you, then what you will say to your patients?
Okay, so this is a common question. A patient comes to OPD and says, Doctor, I want to go for the robotic. What do you say? So I say, if you trust the surgeon, then definitely I would go for the conventional. And if you trust the robot, then definitely the options are open. So it's patient's choice, no doubt. If I want to convince him, suppose. So I would say, first of all, if you seen on the internet, there is less pain, or there would be, faster recovery and better alignment and better stability. So definitely stability I can give, but about the pain and the rehabilitation, about the walking as soon as possible, it all depends upon your, willpower and strength. So pain, again, is a subjective feeling. So we can't promise that you have less pain, we have less pain. And if the pain is less, definitely the patient can walk as soon as possible. So this is my things I used to explain to the patient. And no doubt, if patient comes to you for, for a trust that you are going to make him happy, so he can choose you, not the robot.
One thing, Dr. Akhilesh,
Yes,
we have started using robot for last 9 months only. So we were not using it before, but it was available in India and people were using it. So many of this question we have also faced, that whether you'll be doing robotic or not, you have robot or not. So I can simply say, because I've been doing conventional surgery for last 30 years and I will do conventional method. We don't have that robot. If you want robotic surgery, you have to go to a robotic surgeon and understand. If you find okay, you can get it done. So as simple as that, because I don't have it, so I'm nobody to comment on that.
You're right, sir.
One more question. Whenever you are placing pins in proximal femur or the distal tibia, you penetrate only one cortex and the other end is just to avoid fractures. So here, if bone is osteoporotic, so the loosening of this pin is chances are quite high. So then your robot will may give the wrong orientation. And this, I think, Vaishall have that kind of advantage because it gives real-time data in this thing. So this problem is not with not Vaishall robotics, but other robots, I think, have this kind of issues.
No, real-time data, every robotic gives. It gives you real-time data. You can see how things are moving and at what position, what is the position. So that's not the question. That's what has happened. And initially we use it in a porotic bone and it got loosened and we have to abandon that. Now we make it a point, if patient is porotic, more porotic, we avoid. We tell them, okay, this is not a suitable case for robotic. Definitely that's a big risk factor because
multiple checkpoints, sir. There are multiple checkpoints during the surgery. You can check it before the cutting tibia, before cutting the femur, whether your checkpoint is correct. If your checkpoint is correct, you can do the surgery. If there is pin loosening, that checkpoint will deviate from its original position from few millimeters. That will be obvious on the screen as well. One thing I would like to add, Tomar sir, sir, the world literature says that if you are doing a bilateral single sitting bilateral TKR, there are chances of fat embolism that we all know, and that world literature says that mortality of 1% is reported in a bilateral single sitting TKR. What is your take, sir?
No, I don't agree to this, because this the femoral canal penetration we can avoid with navigation also. But I have been doing this bilateral and take very less time, around 1 hour, 10-15 minutes only. I've never faced that. Because
sir, have you faced it? Have you faced any?
Had I ever faced that problem, naturally I would avoid that problem.
Have you ever faced any post-operative saturation fall in the monitor, though patient was asymptomatic, but on third day or fourth day you see the SpO2 is coming beyond 90%, it's coming to 88, 85, 90. Have you ever faced any such situations in post-operative?
For one day patient remain in ICU, so we hardly have seen this kind of scenario, because we have not seen the scenario. I think we try to suck that, we do our own ways, we try to suck that femoral canal and do that kind of thing, and never face that. Had we been facing this kind of scenarios, and naturally we will avoid that practice.
That fat embolism usually reported, sir, is not on the first post-operative day when we put our patients in the ICU and post-operative period. That occurs mostly around 72 hours. Luckily, you are not encountering. Sanjay sir,
it is not exactly the embolic phenomena. The fat embolism, microembolia, they go into lung, and later on they cause an inflammatory reaction, and that causes the problem. And there's no doubt about it. There's ample data to suggest that bilateral has more complications, overall complication, if you do it in a conventional way. I'm not talking about robotic, because that has not been established. Bilateral TKR overall complication is more when you compare it with a single TKR. It is a proven fact, and many of the countries it is not allowed.
Okay, sir. One doctor was sacked by the court for doing a bilateral TKR in Bengal, but I must mostly do a bilateral TKR. You said very correctly, the complications may be more, but I do mostly bilateral TKR. We have to be very careful about it, because one doctor in West Bengal, he was by the court, he was, charged something for doing a bilateral TKR. But there is no such rule in our country. It is our own prejudice and what should we do, what we should not do. But overall, definitely it gives a better alignment, better accuracy, but more time consuming in the beginning. But overall longevity is depending upon the mechanical alignment. This is correct. It is the
longevity is dependent on alignment,
and accuracy,
bone quality, and how patient uses. It's not only the one thing we get. If patient has very good bone quality, very stable knee, even a malalignment will work for a long time. If patient has poor bone quality and varus or a malaligned knee, it is going to fail. So it's a combination of many.
Okay.
It's a combination of alignment, balance.
Post-op rehabilitation is also very important thing in this.
I don't know what is the opinion of the house. Should we go for bilateral knee replacement or not? But one person had embolism.
Already doing it, I personally discourage it as far as possible. We do it. And there was a time I used to do 90% of my cases bilateral. But I discourage them, but it's still younger patient, no comorbidities, no issues. We do it. That's not an issue. Just one word about your pain and those things. Patient satisfaction. Sometimes the patient has paid more. He has gone for a bigger technology, a new technology. That elation itself gives a better outcome. Maybe that is there. one of my patient is from Imran's place. He's from Gorakhpur, and he just sent me a video last week. He was riding a horse. He is a big time, what you can say, a landlord kind of a thing. So they have a horse. So he was riding a horse, and he just sent me a picture. We did a robotic knee in his case about 5 months back. Just because he was the big man in the society. He wanted to show off that I got this done and I'm riding a horse. So those things, they do add to the psychology of the patient, definitely, but we have to analyze it as a specialist. So I think we should summarize now because there is limitation of time. So I would like to thank UPOA, Dr. Santosh Singh sir, and from Ortho TV, Dr. Ashok Shyam sir and Poonam ma'am for associating with this webinar. And I'd like to thank all the speakers and all the attendees of this webinar who have joined, and together we have. I don't know. The sound has become insight on this topic, and the topic, the debate will never end, and we'll come up with a next topic related with this. And I'd like to again thank everyone to those who have given your precious time for this webinar. Thanks a lot. Thank you. Thank you. Debate should never. Nice discussion. Thank you,
Dr. Imran. Thank you very much.
Because that is a sign of death.
So Poonam ma'am will leave this meeting.